Okay, students, this is Sheila and Carrie, and we're going to be doing atrial septal defects. Alrighty, atrial septal defect overview. It is an acyanotic lesion. It can be asymptomatic for decades. It's commonly diagnosed in adults more than peds. It is a left to right shunt, which leads to increased pulmonary blood flow. If that increased pulmonary blood flow is left unchecked, it can lead to pulmonary hypertension, ventricular remodeling, and eventually right heart failure. The shunt will reverse from a left to right to a right to left, which is Eisenmenger syndrome. So it goes from an acyanotic lesion to a cyanotic lesion. An echo can use to diagnose and determine the location of the ASD, the degree of shunting, the direction of blood flow, and any associated cardiac anomalies. And repair is indicated when the pulmonary flow is the ratio of pulmonary flow to systemic flow is greater than 1.5 to 1.
All right, so there are four types of ASD, and they're typically associated with a particular lesion. First one is ostium primum, which is located in the septum caudally above the AV valves. It's typically associated with a cleft mitral valve plus or minus mitral regurgitation. The second is ostium secundum, which is the most common. It's at the middle of the atrial septum, also the same site as the foraminal valve. It's associated with mitral valve prolapse plus or minus regurgitation. Third is sinus venosus, located at the superior or inferior vena cava, associated with anomalous right pulmonary venous return. And the fourth is unroofed coronary sinus, which is at the coronary sinus opening into the left atrium, and that's associated with persistent left superior vena cava. First article is Atrial Septal Defect Closure, Indications and Contraindications by Frazee et al. The article goes through recommendations for closing versus not closing in ASD. Article states that closure is indicated in the presence of a significant left to right shunt that manifests as a right heart enlargement regardless of symptoms. Small defects are not closed unless right to left shunting is present, which is a cyanotic lesion, making it a blue baby, or if there's a presence of paradoxical embolism. Mode of closure can include transcatheter or surgery. Majority of the cases now are completed through a transcatheter because it's less invasive. However, that has its limitations. Surgical closure is recommended when larger ASDs are present greater than 38 millimeters, multiple ASD, deficient septal rims, and complex anatomy. Other limitations of transcatheter repair include a smaller patient. Patients weighing less than 15 kilograms with large ASD have greater risk of complications, so it is a relative contraindication. It's because of the ratio between the size of the device versus the patient's septum. ASD is also often accompanied by atrial arrhythmias such as AFib and aflutter. AFib is most common and it may persist after the repair, especially when the repair occurs after 40 years of age. And the article recommends that atrial arrhythmias are repaired prior to the repair of the septal defect because the implant of the device to repair the defect can make the ablation process more complicated, so that should occur beforehand.
As far as anesthesia management, the anesthetic is approach and facility/protocol dependent. Open surgical approach necessitates general anesthesia due to sternotomy, cardiopulmonary bypass, etc. The percutaneous or transcatheter approach can utilize either general anesthesia or deep sedation. The percutaneous approach via general anesthesia. So NC and colleagues in 2016 did a retrospective review of 25 cases of percutaneous ASD closure. The mean age was 8 years old. The procedure was carried out with general anesthesia and an endotracheal tube as per facility protocol. A TEE probe was utilized to facilitate the closure, and the general anesthesia helped the patient better tolerate the TEE. Hemodynamic instability was better controlled with general anesthesia as compared with deep sedation. The only complication seen was transient bradycardia in 2 patients. So now we move to a percutaneous approach via deep sedation with spontaneous ventilation. So Hanslick and colleagues in 2014 did a retrospective review of 197 cases of percutaneous ASD closure. The mean age was 6 years old. The procedure was carried out with a ketamine propofol anesthetic and spontaneous breathing. TEE was utilized again with great attention to patient airway patency. There were, however, considerably larger number of complications. So the cardiovascular complications from this case included arrhythmias and conduction abnormalities, but these were associated more with device placement and not necessarily deep sedation. The respiratory complications, however, included temporary bradypnea and apnea, which there was 8, excessive mucus production 2, hypoxemia 3, and bronchial obstruction 4, and 2 of those patients needed acute endotracheal intubation.
Our case report is unusual case of left bronchial compression by aneurysmal pulmonary arteries in a child with atrial septal defect. Power et al. So our patient is a 15-month-old female who presents with a dry cough and severe respiratory distress. The patient has a known history of ASD diagnosed at 9 months. She had tachycardia, respiratory rate of 50, absent respiratory sounds on the left lung fields, is severely malnourished, weighing 6 kilograms. Systolic murmur was present on the left upper sternal border. Saturations were 90 and 93% on 6 liters of oxygen. Imaging showed collapse of her left lung on the x-ray. CT angio and bronchogram showed dilation of pulmonary arteries compressing the left main bronchus, 7 millimeters distal to the carina. The bronchoscopy showed mucosal edema and inability to pass the scope into the left main bronchus. Echo showed 3 centimeter ostium secundum with large left to right shunt. Pulmonary arteries are enlarged and pulmonic regurgitation was present. Cardiac cath confirmed the ASD, the left to right shunt, and pulmonary hypertension of 70 over 17 millimeters of mercury.
So this patient underwent open surgical procedure. The anesthetic chosen was a high thoracic epidural block with 0.25% bupivacaine bolus at 0.5 milliliters per kg, followed by an infusion of 0.125% bupivacaine and 2 mics per milliliter fentanyl at 1 milliliter per kg per hour during surgery and 72 hours post. Cardiopulmonary bypass was utilized, the aorta was clamped, the heart was arrested, and the patient was cooled to 32 degrees Celsius. During surgery, the heart is noted to be grossly dilated with a hypocontractile right heart. Pulmonary trunks and branches were also dilated. The ASD was surgically closed with a patch of pericardium through a right atriotomy incision. The right pulmonary artery was disconnected from the main pulmonary artery. It was reduced anteriorly and reanastomosed to the main pulmonary artery anterior to the aorta. Main and left pulmonary artery aneurysmorrhaphy was completed. The patient was weaned off bypass uneventfully. Extubation, the vent settings were pressure controlled, SIMV with pressure support of 20 centimeters water and a PEEP of 10 centimeters water to maintain a tidal volume of 8 to 10 milliliters per kg. Immediate post-op saturation was 84%, which improved to 97% within 4 hours. Recruitment maneuvers were performed. Follow-up chest x-ray showed left lung expansion. The patient was weaned off the vent to pressure support, then extubated 4 days post-op. A 6-month post-angiogram and bronchogram showed relief of bronchial compression and a pulmonary artery pressure of 36 millimeters mercury.
So to tie it all together, the presence of ASD in early childhood is generally benign. However, in this rare case, the patient had pulmonary hypertension, pulmonary aneurysm, and cardiac remodeling at 15 months of age. Airway compression can occur in a cyanotic or acyanotic lesion, and the culprit can be extrinsic, like cardiomegaly, atrial enlargement, or intraluminal, like interstitial edema, hyperactive airway, vessel bronchial enlargement, and lymphatics. The proximity anatomically of the bronchi to the pulmonary artery can lead to occlusion, and in this scenario, 2 modes of treatment was utilized to aid that situation. One was translocating the pulmonary artery anterior to the aorta so that it is away from that tracheobronchial tree, so it no longer is compressing on that, and also the aneurysmorrhaphy. The treatments showed improvement with decrease in PA pressure and reversal of obstruction. And to tie it all back to our previous articles, our first article, Frazee et al., recommended that more complicated ASD repairs and patients weighing below 15 kilograms be surgically treated, and that's what happened here. This patient received general anesthesia and had surgical intervention to repair her ASD. The following includes our reference list.